Well, my name is Alexis Davis. I am the social media manager here at RSDSA, and I'm joined, of course, by Jim Broach, Executive Vice President and Director of RSDSA, and Dr. Stephen Richeimer. Dr. Richeimer holds the academic position of Professor of Clinical Anesthesiology and Psychiatry at Behavioral Sciences at Keck School of Medicine at the University of Southern California in Los Angeles, where he is director of the USC master's degree and certificate programs in pain medicine. These online programs are available to all clinicians. In addition, Dr. Richeimer is chief of the Division of Pain Medicine at USC and director of the Norris Cancer Hospital Pain Management. He is triple board certified in the fields of anesthesiology, psychiatry, and pain medicine. Dr. Richeimer is a member of the American Society of Regional Anesthesia, American Society of Anesthesiologists, International Association for the Study of Pain, and the American Medical Association. He has also published many books and articles in peer-reviewed journals. Now, please remember that while the information shared here tonight on ketamine is helpful, we definitely want to make sure that you are consulting your physician for personalized medical advice. And now, before I turn it over to Jim and Dr. Richeimer, I do want to make a few announcements. We are really excited for tonight's Facebook Live, but we also have two amazing Facebook Lives coming up in the month of April. So we're going to have Dr. Katina Vandermeer from the Sparrow Clinic on Thursday, April 8th. And we're also going to have Dr. Brandon Junger. He is a physical therapist, and he's going to talk about physical therapy and CRPS with one of his patients on Thursday, April 22nd. So more information about those lives will be available on the RSDSA Facebook page, our website, all of our social media channels, our newsletter, which I hope you are subscribed to. So definitely keep an eye out for those items. But Jim, I'll turn it over to you. Any announcements for you?
I just want to wish everyone a happy spring. We're so excited that the weather is getting warmer and that people are becoming vaccinated, and a lot of more interest in our community. And we're really excited about Dr. Richeimer tonight. We've been trying to get him for so long, and he's just a busy man with quite a following. People come from all over the world to see him. So without further ado, Dr. Richeimer, we're looking forward to it. Thank you.
Thank you. It's my pleasure to be here. So I think we have a series of questions that we're going to be working our way through, all regarding ketamine, which is a big part of my approach to treating patients who have CRPS, or complex regional pain syndrome. Alexis, I guess if you call up the questions, we'll work our way through them. This is a big one. How does one get ketamine covered by insurance? So I don't know of any other outpatient program that will obtain insurance coverage besides our own. And that is simply because we will fight with the insurance companies, and most other programs are just not willing to do that. So, you know, sometimes patients can pay cash and then submit the bill to their insurance for reimbursement, but it's not clear how much is going to get reimbursed. Part of in our program, it can take months for us to get coverage by insurance. As I said, I don't know of any other program that does it.
And I will fix the shared presentation really quickly. It disappeared on me for a second. And I'm bringing it back. One moment.
Okay. Okay, so let's go to number 2. Do all doctors use the same formula or protocol for ketamine infusions? Do they all administer it in the same way? The answer to that is completely no. Everybody has their own protocols. There are some protocols a little bit more widespread than others. And our protocol is that patients start with 10 days over 2 weeks. So 5 days a week for 2 weeks. gradually building up their dose. And then after that, we typically go to 2 days a week and gradually over time increase the interval between 2-day infusions until we reach typically 3 to 4 months between 2 days of infusion. And when I say 2 days of infusion, these are outpatient days. We do our infusions over 4 hours in an infusion center. Our maximum dose is 400 milligrams over that 4 hours. Different institutions have different maximums. We have found that we started initially, when this is many years ago, at 200 as our maximum. And we weren't having a lot of problems with side effects. And so we thought we might get more benefit if we increased the dose, which we did. And we're having a few more side effects at 400. So we generally don't go above that, other than very special circumstances, which then require an ICU admission. And this is in our program. I know of programs that go up to 1,000 milligrams. But I also know of patients who have come to me from those programs, sometimes having dealt with side effect issues. So it can be more beneficial at higher doses, but it also has higher risk of side effect. So who is most likely to respond well to ketamine infusions? I have tried low dose inpatient infusions about 15 years ago with little benefit. So we don't really know who is, what's the, if you will, the signs of a good responder. There is some evidence in the literature that acute onset CRPS does not respond all that well, and that more chronic CRPS responds better. Beyond that, we really don't know very much. If you had a little benefit at low dose, the first question, of course, I have is, what do you mean by low dose? If you weren't, pushing 300, 400 milligrams, then I would say it is probably worth trying again, as long as your low dose wasn't limited by side effects. Okay, let's try number 4. Can we discuss ketamine in the kidneys? So the kidneys are generally not a problem with ketamine. There are some reports of people having bladder issues. Pretty much all of those reports are not in a medical setting. They are amongst people who are abusing ketamine and using it in an uncontrolled fashion. In a medical setting, we're really not seeing those kinds of bladder problems. The other issue is it can affect and irritate the liver. And so we do periodically with our patients get blood tests to check the liver. We will look at the kidneys also, but again, that's not usually an issue. If we see the enzymes of the liver going up in our blood tests, indicating that there is irritation, then we will ask our patients to take a break, maybe a couple of months, and then hopefully we can resume. But it's got to be with monitoring of these functions, of these lab tests. Okay, let's go to number 5. What are the short-term benefits most people see? What about the long-term? How often does one need them? Any long-term, short-term effects of ketamine, nasal or IV, or on an individual's cognitive domain? Okay, so that's a big question. Short-term benefits are extremely common, meaning that I would say the vast majority of our patients do get good relief, at least for a few days after an infusion. Once you start talking about long-term, it's still a very good number, but you lose some, meaning if if 90% of patients are getting good short-term relief, we might be dealing with something on the order of 60%, maybe even 70% that are getting long-term benefits. Now, when I say long-term benefits, I don't mean that the pain is gone. I mean that they're seeing improvement. Many of our patients get those kinds of 60%, 70% benefit. Some are only getting maybe 30% benefit, but they still choose to stay in the program because nothing else was giving them significant relief. So many patients are getting that really very noticeable benefit, some less noticeable, but still better than other treatments. Are there any long-term, short-term effects of ketamine? Long-term, we're not really seeing it. Short-term, it definitely can affect cognition. For most people, that's just for a few hours, but for some people, it can last for days. We have a policy in our program that patients are not allowed to drive for 48 hours after a ketamine infusion. I don't know that that's universal amongst ketamine programs, but we consider that a wise precaution. I guess you're also asking about nasal or IV. We don't use nasal in our program. We use oral ketamine, which is typically compounded by compounding pharmacies, or IV, which is what I've mostly been referring to so far. Okay, let's look at number 6. How does one get dental procedures done with ketamine? Where can I find dentists that can do this? I have to partially say I don't know where you can find dentists that do this, but many of the big institutions, academic centers, etc., are very comfortable working with anesthesiologists, either medical anesthesiologists or dental anesthesiologists. Either can be present for dental procedures and can administer ketamine. Some of the private practices do it also, but some are not willing to work with anesthesiologists, either dental or medical, and therefore they probably would not use ketamine. Okay, why do some people have serious or bad reactions or post-infusion flares with ketamine? So if by serious or bad reactions you're referring to post-infusion flares, that I would say is extremely rare. You know, we're running 8 to 10 patients every single day in our program, and I think I've seen a post-infusion flare twice, and that's over about 8 years. So it's really rare. I don't know why. I suspect sometimes it's not even the ketamine. It might be the stress of coming into an infusion center of the ketamine, maybe the comfort of the chair or the bed or the recliner that they're in. But fundamentally, I don't know why some patients flare after a ketamine infusion. Now, by other serious or bad reactions, again, by far the most typical is cognitive. Patients might have hallucinations or other distressing types of cognitive side effects during or for the first hour or two after an infusion. These can be reduced greatly by using Versed, which we use in our program. There are some programs that do not use Versed, believing that it reduces the impact of ketamine. I don't think we have data telling us that it does or doesn't. I don't really think it does reduce the efficacy of the ketamine, and it really does help control these side effects and makes the experience much more comfortable. How often should a CRPS patient get ketamine infusions? Will the patient develop a tolerance to ketamine? Can the infusions be addictive? Okay, so how often? As I mentioned, we start with daily infusions 5 days a week for the first 2 weeks, and then gradually get it down to approximately 2 infusions every 3 or 4 months. But it can take a long time to get down to that kind of maintenance schedule, if you will. Will patients develop a tolerance to ketamine? They do appear to develop tolerance to the side effects. I would say tolerance to the good effects of ketamine appears to be minimal. I wouldn't say zero, because I do think I've seen it in some patients, but I don't see it often, and it's usually not something that really gets in the way of our treatment. Can the infusions be addictive? Well, not in the classic sense of addiction. Patients don't crave the ketamine, and they don't have, withdrawal reactions to ketamine when it's stopped. Nevertheless, if it is the only thing that is giving patients some time of pain relief is addictive, meaning patients really do crave pain relief. And so some patients find it very hard to work down the frequency that they are getting infusions, because it's the only thing that's giving them relief. And if they're only getting short-term relief, then this issue can become a problem that we have to mutually struggle with. How long will the benefit of ketamine infusion last? Well, it says a ketamine infusion. So a single ketamine infusion, I would say typically not very long. There are a few outliers that can get weeks and weeks after a single ketamine infusion, but typically a single ketamine infusion is not going to provide long-term relief. It has to be the kind of program with multiple infusions that I described earlier. Okay, let's go to number 10. Is topical ketamine available as a prescription or only used by researchers at this point? So it is used clinically. I use it clinically extensively in my practice. It is a prescription, but it is not a commercially manufactured prescription. So the prescriptions have to be filled by compounding pharmacies that will take the doctor's prescription and compound or create a cream or a gel following the doctor's orders that can be used topically. And I do think that this is a very helpful treatment. Okay, let's take a look at number 11. What has been your experience with surgery using ketamine in an older patient? Because, for example, somebody who is 70 plus. So ketamine can be, it's a good anesthetic. I would say it's not commonly in modern anesthesiology used as a sole anesthetic. It's typically mixed with other anesthetics, but it is a good anesthetic. The issue is some patients have a lot of cognitive impact from it and wake up sometimes with, distress from their cognitive symptoms. Those can be reduced, but not necessarily eliminated by using Versed and similar drugs. I think, like most medications and certainly most anesthetic and analgesic medications, patients who are older need to use lower doses or be given lower doses. But I wouldn't say that age is an automatic reason not to use. Let's take a look here. The next, can or should low-dose ketamine be given close together in order to get the best response to treatment, like 3 or 4 months apart? Okay, so again, different institutions have different protocols, but in our program, as I mentioned, it's daily for the first 2 weeks, and then twice a week for the next month or two. And then we start giving it every third week, 2 days every 3 weeks, 2 days every 4 weeks, gradually increasing until we get to 2 days every 3 or 4 months. That's our frequency. I'm not sure what you mean by low dose. So I'm talking typically almost all our patients are getting between 200 and 400 milligrams per session. That's spread out over 4 hours. Let's take a look at number 13. What side effects, complications, or damage to organs from low dose IV treatment are the doctors finding? So no damage to organs we are finding. As I mentioned, there are reports, but typically not from medical settings, of bladder damage. Again, we're not seeing that in medical settings. The side effects I pretty much mentioned, they're almost exclusively related to cognitive effects, anxiety, hallucinations, things of that nature. Ketamine does make the heart pump fast during the infusion. And so we do require our patients to get a cardiology clearance prior to entering our program. That basically says that they're not prone to arrhythmias, that they have a healthy heart that can handle, beating fast for the time period of the infusion. Number 14, is ketamine treatment equally effective for all CRPS symptoms? The short answer is we don't know. My clinical impression is that it is better for allodynia, meaning pain with non-painful stimulation, such as light touch. It's better for allodynia than it is sometimes for the deeper aching type pains, though it can help there. We find that once pain starts decreasing, usually the attendant signs and symptoms of CRPS, the swelling, the sweating, the color, the temperature changes, start to improve also. In most patients, I think the pattern we're seeing is pain starts to decrease first, and then those attendant symptoms start to decrease. I'm not telling you that based on data. I'm telling you that based on my personal impressions. Let's go to number 15. What ketamine regimen dose and frequency would you suggest for systemic CRPS symptoms? Basically the same as everybody else. We are not making distinctions between, localized to one limb, multiple limbs, whole body. We're not making those distinctions in how we treat patients with ketamine. It's pretty much the same protocol as I've described, starting with 5 days a week for 2 weeks and then decreasing the frequency, but trying to get the dose up to 400 milligrams, unless they don't need to be that high because they're responding at a lower dose, or if we can't get that high because of side effects. What other complementary treatments would you suggest with ketamine? So in the early phases of treating ketamine, meaning during the first month or two, patients probably don't have much time and mental energy to do too much else. And as I said, they can't be driving for 48 hours after an infusion. So their other treatments become pretty limited. But once they have the time and the space, mental space to do other treatments, then I really think they should be getting the other treatments that I want almost all my CRPS patients to get. which is physical therapy and pain psychology, and frequently also occupational therapy. So I'm a big advocate for those other treatments. I think that they can contribute a great deal. Can you share data on the efficacy of receiving ketamine via IM injections versus IV? No, I'm sorry, I can't. We don't use IM injections, and I have never seen data addressing it. So between my lack of experience and not seeing data, I really can't help you with that one. Let's go on to 18. Do you feel that inpatient infusions are more beneficial than 4-hour outpatient infusions? I think the answer to that is basically no, though there may be an exception. So in our institution, and I think this is very common, there are two kinds of inpatient infusions. One is the standard, which is up to 10 milligrams per hour. And the other is higher doses than that, which in our institution and in many other institutions requires that the patient be in the ICU if they're inpatient and getting more than 10 milligrams an hour. So I think that there are times that the 10 milligrams per hour just provides sort of a steady state that is helpful to patients. But 10 milligrams per hour is 240 milligrams. And in most cases, we can get above that dose during our 4-hour infusion. So in most situations, I think the outpatient infusions, are just as beneficial or more beneficial than the inpatient infusions. How long have these infusion treatments been used for pain or depression? Have there been any long-term studies on possible future effects? So as far as I know, Drexel Medical Center in Philadelphia has been doing these infusions longer than anybody else. And I think we're talking about 16 or so years there, maybe even a bit longer. And so far, we're not seeing that there are reports of, any kind of long-term side effects. In terms of it's being used for the treatment of depression, I know a lot less. I'm not sure when those treatments were first started. So I can't really address that. Okay, let's take a look at number 20. Is there a different ketamine treatment protocol for treating CRPS that is spread to multiple areas of the body versus those patients that have limited spread of CRPS? And again, in our institution, no difference. The protocol is exactly the same. Arguably, those patients who have more than one affected limb are going to do better with ketamine, which is a system-wide treatment, than they might do with other focal treatments. Nerve blocks, which we use a lot in our program, are typically focused on one limb. Spinal stimulators or dorsal root ganglion stimulators, most commonly on one limb, occasionally two limbs. So the advantage of ketamine for patients with multiple limbs is it's inherently systemic. It goes IV to everywhere in the body. Okay, well, I think we got through our initial set of questions, And maybe Alexis has gathered a few more.
Definitely. So hello, everyone. Thank you for going through those first 20 questions. I'm also going to bring Jim back on as well, because we have been in the comments taking a look at some of the questions that we have received. So if you are watching us live, continue to add some of your questions into the chat because I have been collecting them. And we will not repeat questions that have already been asked, of course, but I've been collecting ones that have not come up yet. So I know we kind of briefly touched on the ketamine nasal spray, but I just want to make sure I didn't miss this. Would you say that ketamine nasal spray is effective?
So the nasal spray is just another way to get ketamine into the body. And yes, it can be effective. We don't use it in our program because there is a lot of, if you will, kickback about using nasal ketamine. Anything you give nasal enters the body faster than oral and can cause more rapid mental status changes. And in some people's eyes may be more prone to abuse. So we don't use it. Obviously, it's not as fast as IV, but IV is in a very controlled setting, whereas the nasal is at home. So we don't use it. We use either oral or the IV program that we've been talking about.
Okay. And somewhat related to the question, when you mentioned how some people think of the different ways to take ketamine as abuse. How common is the prescribing of oral ketamine, given the status of opioids and all that discussion that's happening here in the States?
How common is it that it is prescribed?
Yes.
So outside of pain specialists, I would say extremely rare. Among pain specialists, I would say it's still not super common, but gradually becoming more common. It is a controlled substance, but it doesn't have many of the risks of the opioids. And therefore, many pain doctors are beginning to think that it can help their patients get off of opioids, be what we call opioid sparing. And which I believe it is opioid sparing, and I do use it to help my patients reduce or get off of opioids. And frankly, I think it is more effective and better for neuropathic pain in general than opioids. Neuropathic pain, by the way, is the large area of which CRPS is one example. By neuropathic pain, I am meaning pain that is caused by malfunctioning of the nervous system.
Dr. Richeimer, may I ask a question? After the ketamine, would you be utilizing any other medications to maximize the benefit between infusions once they're into maintenance dosage?
Did I understand correctly? What will help maintain them in between the doses?
Yeah, any medications that you're utilizing.
Yeah, so the three most common that we use is oral ketamine, compounded, amantadine, because it is also an NMDA receptor antagonist, and memantine for the same reason as amantadine. So those are the three most common for us. We occasionally will use dextromethorphan, but we haven't had as much success with that as with the others.
Okay, thank you. Alexis, please.
So we have a question here from Karen. What stage, in someone's CRPS journey are infusions most effective, or does it matter? If it's someone who just was diagnosed, someone who's had CRPS for many years, what are your thoughts there?
So there is a small literature saying it's not really as effective for acute onset or new onset CRPS. And typically for the new onset patient, if it's really brand new, I probably would treat the patients with steroids. If it's a little bit past brand new, then I initially will treat them with everything else, which consists of, you know, the physical therapy, the psychotherapy, the nerve blocks, and possibly bisphosphonate infusions, which can be very helpful, especially in the first year that a patient has developed symptoms.
Somewhat along those lines, would you use ketamine on a younger patient, like maybe a teenager who's just, well, not, maybe a teenager who's had CRPS for a while, maybe someone who's like 14, 15?
Personally, no, because our institution doesn't do pediatric care. I do believe that some of the institutions that do pediatric care do use ketamine in teenagers, but I really don't have any experience with that.
Okay. I have another question here. Someone's asking, you know, more about the details of ketamine. So what is the actual mechanism that causes the pain reduction? Is the ketamine modifying the pain receptors? They kind of want more of the science behind it.
Okay, I'll try to do a capsule of that to the level that we know. So we know pieces of the puzzle, but I am sure that there are many pieces of the puzzle that we don't know yet. So ketamine binds to what's called the NMDA receptor, which is a receptor channel complex. So this receptor is sitting on nerves, on sensory nerves that transmit pain signals. It is the area that we are interested in is in the spinal cord. So if somebody has pain coming up from a periphery, you know, a signal coming up their arm, let's say, to the spinal cord, in the spinal cord, there's a synapse where one nerve has to signal the next nerve, and the next nerve will carry the signal up to the brain. So in that synapse is where the action is occurring that we're interested in. And by what happens is when the first nerve releases neurotransmitters, chemicals that tell the next nerve to fire, part of what they do is they activate what is called the NMDA receptor. And when the NMDA receptor is activated, it opens and it allows calcium to flow into the second order nerve, that nerve that's going to carry the signal up, and makes that nerve more sensitive to pain stimulation. So we would like to block that channel, and ketamine does that. Ketamine blocks that channel so calcium doesn't get in and the nerve does not become sensitized. So you can see this very quickly. If somebody, you know, hurts themselves and you give them a blast of ketamine, it'll reduce their pain, almost any kind of pain. But then how do we make that an ongoing process that gives people with chronic pain such as CRPS lasting relief? And that seems to be where the multiple prolonged infusions make a difference. When those receptor channels are blocked, when those receptor channels are blocked for prolonged periods of time, it seems to give those what we call second order neurons, the ones carrying the pain signal to the brain, seems to give them a chance to sort of relax, if you will, to unwind, to desensitize. And that, we believe, is the primary mechanism. But there may be other mechanisms that we don't even know yet.
I have a few more questions, but Jim, I wanted to know if you had a few more that you've seen.
I just wanted to make everyone aware that we do have a nationwide list of ketamine providers, and so we can make that available if they email us at info@rsds.org.
Yeah, that's good for me to know. I didn't know you had that. That's great.
Definitely been collecting it over the years. So yes, info@rsds.org, and I will put that in the chat after I ask this next question. So can you talk about the 3-day ketamine awake coma that some people discuss, and what suggestions do you have for those who might not be able to handle the hallucinations that come from ketamine?
So I don't know much about the 3-day awake coma protocol. Basically what I would tell patients to pay attention to is the dose. What is the dose that they are getting? And as you start to get much above 400, 500 milligrams, then you start to see, we're getting some feedback in the system, by the way. I don't know if there's anything we can do about it, but as the dose goes up, the risks go up. And again, usually, unless you're talking about very high doses, these are not like life-threatening or permanent risks or anything like that, but it can make the experience much more unpleasant if there's high levels of anxiety or what we call depersonalization or hallucinations or things like that. So I would encourage patients to pay attention to the dose and seek programs that work them up gradually and that have good monitoring of them while they're getting the infusion. And again, I subscribe to the school of thought that says Versed is not lessening the benefit, but does lessen the side effects. So I think if they're getting below 100 milligrams, it may not be so necessary. But when you start talking about doses that are higher than that, then I think the Versed class of drugs can make a big difference in how comfortable the experience is. Jim, you're muted. Still muted.
Sorry about that. Since we're dealing with a worldwide audience, could you kind of help people to understand how they might evaluate someone who they don't know who's giving, because it's the Wild West out there. And there's so many clinics using so many different protocols. How does someone really evaluate whether they put their money into this treatment beforehand?
Yeah, well, I think what you want to find out is what is their protocol? Do they start at a low dose and work up? We start our patients on 80 milligrams over 4 hours, so it's 20 milligrams an hour. I think you want to know that you are being watched and monitored. So, nurses should be readily available. You shouldn't be off in a corner, and if you have a problem, nobody will know. Our program on almost all days, it's one nurse for every 2 patients. So it's pretty intense monitoring. And for instance, if a patient needs to go to the bathroom, they need a lot of help. You're pretty intoxicated during this.
Yes.
So you really want a program that has that kind of monitoring, has a protocol, I would say that has some experience. I guess every program has to start somewhere, but I'm not sure you want to be their first patient. So,
well said.
So just a few more questions. I know that there are a few that are coming through in the chat if you're watching live here on Facebook that have already been answered. So we're going to, just try to make sure that we are moving forward with newer questions. However, there was one that I think some people are trying to get the spelling of. I believe you mentioned 2 medications or doses that you use in between infusions. I think someone's just trying to get the spelling of those, or just the pronunciation of those.
So one of them was amantadine, which is amantadine, and the other is memantine, which is MEMANTINE. And both of those are drugs that are created, like a lot of things in the pain world, are created for unrelated purposes. But we know that they are NMDA receptor antagonists, and we make use of that.
Okay. So a couple other questions. Do you have maybe an approximate percentage of those with CRPS who go into remission after a series of ketamine? Have you seen that frequently?
Yeah, no, well, so unfortunately, I wouldn't say frequently. I would say true remission, I only see maybe 5%. It's not a big number. On the other hand, the flip side of that is that only about 10% of our patients drop out of the program because they get so little relief that it's not worth it. So, you know, we're seeing the vast majority of our patients are sticking with it. As I mentioned, sometimes not because they're getting great relief, but because they're getting more relief than any other treatment was offering them.
Okay. And then another question. So we are big on advocacy here at RSDSA. We have an advocacy committee. And if you are watching, you are definitely free to join that committee. Just send us an email at advocacy@rsds.org. But what can our community, RSDSA and CRPS warriors do to help support and educate physicians on ketamine, on higher dose ketamine? Like, what are the different things that we can do to, you know, keep this moving forward?
Well, I haven't checked in several months, but if I'm not mistaken, your organization keeps a really nice library of articles that support the science behind this. So I think your advocates should be aware of that and feel free to send these articles to doctors who need to learn more, particularly pain doctors. I would say that non-pain doctors are just not going to be interested in say, you got to go to a pain doctor. So, you know, if you're aware of a pain doctor who doesn't have any experience in ketamine, send them these articles, you know, point them to the library that you guys maintain. Mm-hmm. And then a tougher task is the insurance companies. So, you know, if you're trying to get ketamine, you're going to have, as I alluded to in the very beginning, a really hard time getting insurance coverage. And most programs, because it's so hard, most programs are not willing to keep up the, you know, the appeals and fighting. But you can be your own fighter and, you know, send the articles and harass your insurance adjuster and try to get it covered. And I think over time, that'll make a difference.
Anything else, Jim? Any other items that you want to cover that weren't covered in the original questions as well?
I think I saw a question, Dr. Richeimer, about migraines. And a lot of people have migraines before the onset of CRPS. Does ketamine have any, to your knowledge, any effect on quelling those migraines?
So we actually do have a few patients that we treat for, I won't always say migraine, but I'll say headache, that has not responded to more traditional treatments. And the neurologists ask us to try the ketamine. And we've had some good successes with it. And there is one physician, I have blanked on his name, out of Texas, that has published a case series of using IV ketamine to treat headache. Okay. So yes, it can help. Occasionally, we see ketamine trigger headache. And we have been pretty successful in treating that when it happens by including magnesium with the ketamine infusion. And magnesium is also to some degree an NMDA receptor antagonist. So it actually goes together very well with the ketamine and is not a problem for us to do when, when we think it's indicated. So that often will solve the problem of ketamine-related headaches. But even without magnesium, we occasionally use ketamine to treat headaches.
Thank you for that.
All righty. Well, I have been checking. I know there are some questions that have come through that we have gone over. So I guess, Dr. Richeimer, if people still have questions for you, is there a way for them to get in contact you? Should they email us here at RSDSA and we can send over the questions? What are your thoughts?
Yeah, that would make a lot of sense, I think. If patients are in Southern California, then we're happy to see them, and they can call our pain center at USC, and would be happy to consult with them. We're a group of about half a dozen pain doctors, and pretty much all of us have a lot of experience with complex regional pain syndrome. So we'd be happy to see you if we're geographically desirable. So.
People were concerned about a waiting list at USC. Is there one?
Massive. And the problem is, and I alluded to this in the beginning, is that as far as I know, we're the only ones who will fight to get insurance coverage. And so I would say before COVID, we were running a waiting list of about a year.
Wow.
And now it's probably about 2 years. Because with COVID, we had to slow down for a while. Now we're back up to full speed, but it's close to a 2-year wait list.
That has reduced the people flying in to see you.
Yeah.
Definitely. So we have a good number of resources, a good number of notes. So I did add in the chat, there is a link from ASKP, the American Society of Ketamine Physicians. And I did put that link in there because there is a map that they have that has ketamine providers near you. So I did put that in the chat. We also have a ketamine list here at RSDSA. So you can definitely send us an email at info@rsds.org. And we can not only send you that ketamine list that we keep updated regularly, we can also send you a list of physicians that know and understand CRPS across the country. We are always updating these lists. I think we update them almost every single day because physicians do move, they retire, new physicians are, coming on the scene. So if you are looking for a new physician in your state, definitely send us a message here on Facebook or send it to the info email. You can also find numerous ketamine resources on our website. If you just go to rsds.org and search for ketamine, you'll be able to find a host of resources there as well. And I also wanted to remind you all that, whenever we send over our lists, they are by state. We unfortunately can't do city lists because there's so many cities in the US, so they are by state, but definitely, reach out to the numerous physicians in your state because, you may see a chiropractor like Dr. Katinka. You may think, well, I don't know if a chiropractor will be able to help me, but, there are definitely different physicians who can help in different portions of your, CRPS journey. So I definitely wanted to know that. And now, like we said, if you have additional questions, you can send them to info@rsds.org. And we will also keep this video pinned to the top of our Facebook timeline until our next Facebook Live, so you can rewatch it if you did miss some of the questions. And we're also going to add it to our YouTube channel because we know that there are some warriors who definitely like to watch us on YouTube. So once again, if you need anything that we just mentioned, if you need a support group, or if you're looking to tell your story on the RSDSA blog, once again, the email is info@rsds.org. And that's it for me. Any last words, Dr. Richeimer or Jim?
Just, Alexis, we also have support groups too. There's a number of great support groups on Facebook, and there's a limited amount of face-to-face, but we could send that out to people or send the link. And if you're interested in starting a support group, we have some great resources and individuals who could help you because, as you know, too often that people with CRPS are isolated and feel alone, and we don't want that.
Definitely. And there was a link in the chat that linked to a Facebook group called Ketamine Infusions for Better Health for CRPS, chronic pain, and mental health. So we will add that to our support group page and also make sure that we repost that in the description of this video so everyone can join if you're interested. So Dr. Richeimer, any last words?
I don't think so. Pleasure working with you, and I hope this is helpful.
It's been helpful. Thank you so much.
My pleasure. Thank you. Bye-bye.